Okay, good morning everyone. So today is our case on a infective conjunctivitis. So basically, what is our learning objective? So our learning objective is to find the clinical signs of the conjunctivitis, to differentiate between infective conjunctivitis and non-infective conjunctivitis. Number three, differential diagnosis of infective conjunctivitis and how we manage the conjunctivitis case. So I am Moina Kumar Sarkar, consultant optometrist. So let's start. So first, when a patient come to your clinic, the first thing always start from our observation, right? So let's see what is the case is today. So a 45-year-old male, occupation by electric mechanic, come with a complaint about the redness, discharge, and swelling in both eyes, associated blurring of vision and mild pain since 3 days. All of this history point is very important because you see that redness, discharge, and swelling, if these three are present, then this indicate a inflammation along with discharge. So why? Because the eye becomes red. When the eye becomes red, it may be causes of acute anterior uveitis and also the conjunctivitis also. If the infection is present, then there should be a thick discharge. The discharge should be mucopurulent or a purulent type discharge. So mucopurulent means there is a mucus type discharge mainly, and which purulent discharge means there is a pus type very thick discharge. So if there is an mucopurulent or purulent kind of discharge, you may suspect that this is a bacterial conjunctivitis, because in cases of viral conjunctivitis you may see a watery discharge. Okay, so in this case you see that there is an mucoid or mucopurulent type of discharge. So that is a clue that leads to your diagnosis about an infective conjunctivitis or specifically bacterial conjunctivitis. And by this nature of the discharge, we can differentiate it from other conditions like acute anterior uveitis and the congestive acute congestive glaucoma, right? So next we got to the history of present illness, like history of trauma during work. He fell down from ladder. So he fell down from ladder, as you can see that there is an ecchymosis of the lower lids. Ecchymosis. Okay, ecchymosis means the blood clotting, right? So that is the main cause of the ecchymosis is basically the blunt trauma to ocular adnexa. So or it is also known as Rekunai or panda eye sign. So now there is an history of trauma during work. He fell down from ladder. No history of using glasses or no history of previous ophthalmic consultation. Redness and discharge were first started to his son. Yes, there is a very important point that redness and discharge were first started to his son. After that, his all family members are affected with same condition. This is a very important part of our history, because bacterial conjunctivitis is not virulent in nature. It not easily spread from man to man. Only the viral conjunctivitis is there, who can which can spread from one person to another person. Okay, we know that the recent epidemic conjunctivitis occurs in many areas or many localities in our countries. Due to this epidemic, basically in rainy season, it occurs most in this year. So we may suspect that if that his son was affected first, then his all family member affected first with same condition. So there is also a viral involvement, right? So next come history of past illness, means no history of diabetes mellitus and hypertension, arthritis, etc. Why you have to ask? Because if there is a diabetes patient, if there is any corneal involvement occurs, this may take much more time to heal. Like for a let's take example of a keratitis patient. If a keratitis patient have diabetes mellitus, the keratitis may not be healed so quickly, or in fact in many cases due to diabetes the healing process is very slow. So history of diabetes is very important here, and also arthritis, because the history of arthritis is also associated with uveitis. Okay, so no history of smoking and other family history is nil. So look that his distant visual acuity, right eye is 6 by 9 parts and left eye is 6 by 12. The vision is very important here, because in other cases of the acute red eye conditions, let's take the acute angle closure glaucoma, the vision not be the 6 by 9 or 6 by 12. It may be some odds, right? Or any case of preceptal cellulitis or orbital cellulitis that may also causes the acute red eye. The vision is not too much good. Okay, 6 by 9 and 6 by 12, you can say that this is a good vision. Ocular motility is full free painless in all direction. So here in this case that vision is taken after cleaning the discharge and lashes with NS and cotton bud. NS means normal saline water that is present in our OPD clinics. So we have to clean it first, because in sometimes discharge is so much thick that it stick the lashes, or it reduces the visual acuity it reduces the visual acuity. Okay, because sometimes discharge may be on the corneal surface, and that may cause blurry of vision. So you have to properly clear the discharge before taking the vision. So then refraction is deferred here because discharge was very severe. Now comes ocular motility is full painless in all directions. Okay, so next take here is the slit lamp findings of the patient. Is that we see that all the slit lamp findings are written here. So I not explain details. You may see in that cases that the right and left eye is little different. In left eye, in cornea, there is few SPKs identified with fluorescent patterns. SPKs located paracentrally, not centrally. We see that there is no dendrites are present, and corneal sense is normal with cognitive applicators. So we have to check the corneal sense or corneal sensitivity with a cotton tip in the four quadrants, like superior part of the cornea, temporal part of cornea, nasal part of cornea, and temporal part of cornea. In four quadrants we have to check the corneal sense, because in cases of viral conjunctivitis the corneal sensation may be reduced, or in many cases with adenoviral conjunctivitis, if HSB is present we may suspect it also with the help of reduced corneal sensation. So in this case the corneal sense is normal, so I diagnose that there is no such much no HSB involvement. Okay, just only few SPKs may be present. The SPKs, so why the SPKs? So what I think that in left eye conjunctival in conjunctiva there is follicles present, and somehow in left eye this due to these follicles that rub against the cornea, and due to the mechanical trauma by the follicles, these the left eye cornea there become some SPKs formation. What I think, but not sure about this mechanism. Okay, so let's see that other cases that PACD is normal, deep and quiet, no cells and flare are noted. Iris normal, color and pattern both eyes. Pupil is round, regular, reactive. Lens status is normal. Slit lamp finding is very important in these cases also. And again we see that follicles is also present in right eye, but the right eye there is no not so much SPKs and corneal involvement. So maybe this is the reason. Maybe the right eye vision is little bit good, 6-9 parts, and left eye vision is poor, 6 by 12. And also the things to be noted that the SPKs are not present centrally, it is located in the paracentrally. So next thing is to the differential diagnosis. There are the very much differential diagnosis: acute anterior uveitis, acute angle closure glaucoma, scleritis, allergic conjunctivitis, bacterial conjunctivitis, preceptal cellulitis, severe dry eye, viral keratitis, congestion, secondary bacterial root trachoma, endophthalmitis, parophthalmic blepharitis, and corneal foreign body. We have to rule out all these cases, right? So after ruling out on the basis of examination, so what point we see that the history of there is history of trauma but not severe trauma. So we may no history of moderate to severe pain, only mild pain is present. If the severe pain was there, we may suspect there was acute uveitis or acute congestive glaucoma, but the pain is not severe, means the only the mild pain is present. So there is no chance of scleritis also, because in the case of scleritis, acute uveitis, and angle-closure glaucoma, patient may express both type of pain. In many cases of acute and congestive glaucoma, what I see that the pain is so severe that sometimes patient also may vomit due to this pain. They cannot tolerate the pain, so the pain is not so much. So you can suspect that this is not due to uveitis or acute congestive glaucoma or scleritis, because these three kind of pains are so bored pain, and in fact in the pain of scleritis is also the kind of bored type of pain. Okay, So you can suspect that these three are not there. AC is clear, pupil is reactive, PAC deep in Van techniques. So that indicates that the that AC is clear and PA and no cells are clear means there is no acute and uveitis. This of uveitis is totally ruled out here. Oculomotility feel free, painless, no complaint of diplopia. Why it is important? Because we see that the in cases of cellulitis, in case of preceptal cellulitis or orbital cellulitis or any kind of orbital inflammation that spread from the sinus. Okay, there should be a sign. In fact, in proptosis, there may be sign of red eye also present. In that cases, ocular motility may be affected, and also diplopia. Patient may complain of diplopia. No history of recurrence. So recurrent attacks means it is not cases of episcleritis, scleritis, or any kind of uveitis. Visual acuity is fairly good in both eye, not evenly reduced. Again, I say that visual acuity is fairly good. 6/9 parts and 6/12. You cannot say that this is too much poor vision. Okay, that may lead to your other cases like acute congestive glaucoma or severe acute anterior uveitis. Okay, no history of recurrent vasculitis, diabetes, etc. No history of itching, subconjunctival hemorrhage present. Another fact that no if defect corneal irritation only left eye has mild SPK, corneal cells is not reduced means we can rule out the keratitis also. Bilateral redness is present associated with discharge and redness in both eye with subconjunctival hemorrhage, and his son is affected first. So here is it is very crucial point that his son is affected first, then his family member. In his locality there is also same cases is observed. Here history is very important because we see in the adenoviral keratoconjunctivitis, this is very in epidemic keratoconjunctivitis, it's a very much virulent in nature. Okay, so what I have diagnosed here that the patient may be affected first by viral conjunctivitis. Then, due to viral conjunctivitis, somehow due to his because the patient is electrical mechanic, so I think the patient is not so much in so highly socio-economic condition. It may be some poor environment or poor hygienic condition, so that the viral due to the viral conjunctivitis, the immunity system of the patient become compromised, and so there was a secondary bacterial growth of the both eye. And in left eye, as there is corneal involvement because of the SPKs are there, so we can say that left eye has secondary bacterial growth with keratoconjunctivitis. So what I diagnosed that both eye viral conjunctivitis with secondary bacterial growth in both eye, or epidemic keratoconjunctivitis in right eye and epidemic conjunctivitis in right eye, because in right eye we do not see any kind of corneal involvement, and in epidemic keratoconjunctivitis in left eye, kerato means the in left eye we see there is an SPKs or corneal involvement, secondary bacterial growth, and subconjunctival hemorrhage is also present. Yes, there is a lot of subconjunctival hemorrhage present in cases of epidemic keratoconjunctivitis. In fact, this patient has a history of trauma in the eyes when he falls down from the ladder. Okay, but but this trauma is not severe trauma because it is in cases of if the trauma was severe, there is another other signs of symptoms are present. Okay, so that symptoms are not here. So what the management should be given in these cases? So the management of right eye and left eye should be different. As you know, because in left eye the cornea is involved and the right eye there is no corneal involvement, right? So what things we do at first, ask the patient to clean his eyes with saline water. Saline water means the normal saline, balanced saline salt, salt salad which are present in pharmacies. We have to ask to wash the eyes with that water, or there is very or a good that iodine. We can use povidone iodine ophthalmic solution, which are present in pharmacy also. Okay, povidone iodine ophthalmic solution is best here because in povidone iodine solution is a very good antimicrobial agent. So we have to ask the patient with the cotton tip applicators or any kind of cotton buds, just clean his or her lashes regularly 4 to 5 times, so that the discharge should not accumulate here, because if there is discharge is accumulate, so then it will cause problems. So we have to first observe these cases. So we have to clean the eyes, we have to maintain the hygiene, not share the towel, not share the same bed sheet or any kind of other things. Maintain good hygiene. Then as the patient is moxifloxacin is the have also bacterial conjunctivitis, because thick kind of discharge, that is mucopollulant discharge the patient have. Okay, so we go with broad spectrum antibiotic like moxifloxacin eye drops in right eye 4 times per day, and CMC eye drops 4 times per day also use. And now chlorocol ointment. Ointment. Why ointment? Chlorocol chloramphenicol is a broad spectrum antibiotic. We know. So the 2 times we give the 2 times, because first in at the night time we actually don't use drops. So because the patient becomes sleepy on that time. So what happens if we give the ointment in the night time? So in night time the contact time of the ointment is more than the drop fast. And the second is, if morning time and the night time we give the ointment 2 times, due to its high contact time in nature, it may also act as a good option in that cases, because in cases of whole night time patient not going to open his eyes, right? So we can use the chlorocol ointment. Left eye we give the same management, but in cases as the cornea is involved, we may go with the viral X ointment 3 times per day. Viral X means the gencyclovir ointment 3 times per day. And now come moxifloxacin eye drops 6 times per day. Why I give viral X ointment in the left eye? Because what I suspect that if in left eye there is a corneal involvement, this may lead to viral keratoconjunctivitis. So, detailed pharmacological mechanism of viral eggs, and viral eggs means gencyclovir and acyclovir, and their effects on the various viruses, if I will discuss in my next videos. Okay, so next come that the oral paracetamol 650 mg BDPC doses, what I give that, because in these cases nowadays there is a high risk of systemic inflammation from this condition. Maximum patient when come to a clinic, they may be affected from fever, or the episode of fever occurs first with the from the effect of the conjunctivitis. So oral paracetamol what I give, and oral paracetamol is give what I give, because to reduce the systemic inflammation and nothing but. And also where needed means I prescribe him SOS dose. Okay, so next come cold compress. So we see that there is a huge subconjunctival hemorrhage, right? In our standard textbook there is written that in subconjunctival hemorrhage you have to apply the cold compress, but here you should not do the cold compress, because if the cold compress we give, there is a risk of bacterial growth will increase. So patient till now patient did not come for follow up. If the patient come from follow up, I will definitely post the in picture of the patient after my medications are prescribed. Okay, so thanks for watching. I think as an optometrist we have to as an optometrist we have to very accurately examine the history and history part of the patient, and very accurately examine the patient to slit lab and all the point, because look, because the patient who come in these cases, if the inflammation is not controlled, it may lead to keratoconjunctivitis, severe form of keratoconjunctivitis, maybe ulcer, maybe corneal, it leads to corneal ulcer. Okay, so proper appropriate management at the primary level is very much essential. So that's all. Thank you for listening.